Welcome to Ask Dr. Geier Live, wherever you're watching. I hope you're making today your masterpiece. My name is Dr. David Geier, triple board certified orthopedic surgeon, sports medicine specialist, and anti-aging and regenerative medicine expert. I help you feel, look, and perform your best regardless of age or injuries. Yes, it is that time, the one place that I answer your questions, whether it's an orthopedic injury, surgery, recovery, rehab, maybe it's a health and wellness question. This is the one time and place I do it. I've been getting so many questions, more than, it just keeps growing exponentially, especially on YouTube, questions about people's injuries or whatever, wanting medical advice. And as I say all the time, I can't give you specific medical advice, but I thought I would do this show a little bit early because of that. And last month, I had to do it at the very last minute, earlier than normal, so I know a bunch of you actually missed it, so I am here for that. Couple things. If you're going to ask a question, leave it in the chat, not in the comments. I can't see the comments if you're on YouTube, so it needs to be in the chat. That comes through to my restream, and then I can not only see it, but I can put it on the screen. This is also the first Ask Dr. Geier Live that I am broadcasting live on X, formerly Twitter. I love X as a platform for viewing content. I don't post much on it, but I am trying live streaming on it there today. I don't know how well the questions or comments come through from X to Restream. So if you keep asking a question and I don't get to it, I don't address it, then maybe assume it's not coming through X. We will certainly see that, but I do know it works on YouTube. That's a lot of the reason I've gotten away from doing it on Facebook, is that was very unreliable. LinkedIn as well, unreliable for the comments to be coming through, and so I went to basically just doing it on YouTube. Also, please understand, I am not giving you medical advice. I haven't seen you, I haven't examined you, I haven't looked at x-rays or MRIs. I'm not your doctor, you're not my patient. I legally cannot give you medical advice online, and no doctor can unless there is a doctor-patient relationship. I can get into the legalities. I've talked to an attorney that specializes in this, so just know I am not giving you medical advice. The point of this is to allow you to understand maybe what your orthopedic surgeon told you, or if you haven't seen an orthopedic surgeon yet, understand it a little bit better so that you can ask appropriate questions of that doctor and get answers to help you make the best decision possible. So I'm trying to give you insight on this particular topic, but I am not giving you medical advice. All right, let's start with MD Muhammad. I don't know if I'm saying that right. And I do like it, if possible, for you to give your first name and where you are. I always like to know where my viewers are coming from. I think it's really cool. I've got so many international, so that would be great if I could. All right, he says, I had a scaphoid fracture almost 10 months ago. Still feel some pain when I rotate your wrist. Well, I think a couple things. Scaphoid fractures, find my wrist model here. The scaphoid is this large bone, let me kind of show it to you this way, at the base of the wrist, sort of under the thumb, and that bone is notoriously bad at healing, both source of stress through the wrist and impacts there, but also very poor blood supply to that region. So typically, and that's why they almost always, not almost always, but the vast majority of them at least, end up needing surgical treatment, even if it's really lined up well. Very often that needs surgical treatment, or at least the hand surgeons in the United States a lot of times will just put a screw across it just to make sure it heals and to minimize the chance that it develops what's called avascular necrosis, where a part of that bone dies due to lack of blood supply. So that's the first thing that I would say is somebody that is still having wrist pain after a scaphoid fracture, I would want to make sure that that fracture heals. Go back to the hand surgeon or the doctor that was taking care of it. Make sure on x-ray that that bone healed, but then also make sure that you aren't slowly developing arthritis in that area, which is unfortunately not all that uncommon occurrence after a scaphoid fracture. Those can do very well, if treated appropriately, very early on. But if it becomes a chronic thing or if it's missed, and I've recorded a number of videos about that, it can be a challenging problem. I hope it's nothing in your case. Maybe it's stiffness, they haven't gotten full range of motion back, but those would be the things that would certainly cross my mind. All right. Salam, sir. I don't know what that means, but maybe as I keep going, there'll be a question related to that. Georgia says, wish me luck going for hand surgery tomorrow. Georgia, a frequent visitor, viewer, participant on these Ask Dr. Geier live shows in Greece, which is that's really cool. Georgia, I do wish you luck. Hand surgeries, and I say this as a sports medicine physician, sports medicine orthopedic surgeon, so I never really did hand surgeries, because the hand surgeons, at least here in the United States, that's all they do, and everybody else in orthopedics doesn't do any hand surgery. But the surgeries generally are pretty straightforward, but they're surprisingly long in the recoveries. So that is just something I always tell my patients that have to go to see a hand surgeon for hand surgery. Just expect it's a pretty long recovery time, but I hope it goes great. Definitely fill us in on our next show how everything is going. All right. Mary, Georgia, good thoughts coming your way. I am glad to hear that. Mary, another person that participates a lot in this show, very glad that you are here. All right, this is now going back to the person that I posted earlier. I've undergone ACL medial lateral meniscal repair 5 weeks ago, having problems with knee flexion. My knee feels like it's stuck when it's bending hardly 30 degrees. So it's hard to know in your case specifically, and it says Omar, if that's your name. I'll just call you Omar because that's what your user YouTube handle says. Omar, it's hard to know in your case why you're struggling to get range of motion back. In my, 16 years, I guess, that I was a sort of a normal orthopedic surgeon, sports medicine surgeon, where I was doing surgeries all the time. I've sort of pivoted to anti-aging and regenerative orthopedics. But having said that, I probably did over 1,000 ACLs in my career. Lots and lots of those with meniscus repair surgery. Even if everything goes well, getting range of motion back after an ACL surgery can be challenging. And the key with it is you've got to get it back very quickly. Again, not medical advice, just generally patients need to get their range of motion back. My rule of thumb working with patients after an ACL is I wanted them to have full extension almost immediately, but certainly getting it by as no later than 4 weeks, meaning easily being able to get your knee all the way flat to a sofa, couch, bed, table, whatever. And then as far as bending went, I wanted 90 degrees, ideally by 4 weeks, but certainly no later than 6 weeks. Now, some of that gets to, in the case of a meniscus repair, a lot of surgeons, and I was one of those, that I did not allow the knee to bend past 90 degrees for the first 6 weeks to protect the repair. So that involved sometimes using a brace that was basically set to stop at 90 degrees. But I did want to get to 90 degrees, and then after 6 weeks, try to get full flexion back. By 6 weeks after an ACL surgery, I have found it's really hard to get that motion back without doing something like scoping the knee and cleaning out scar tissue, what we call an arthroscopic lysis of adhesions, sometimes with a manipulation, although just a closed manipulation, I would be a little concerned, am I doing harm to what I just had surgery for, ACL and the meniscus repairs? But it's a lot of work early in that first 6 weeks with a physical therapist. It's a lot of work on your own doing exercises, but those are typically the guidelines. So again, this is not medical advice, but at 5 weeks, I would be back in the orthopedic surgeon's office saying, all right, I only have 30 degrees range of motion. What can I do over the next few weeks to get closer to full range of motion, or do we need to start thinking about some kind of procedure to get it? That's just how I would look at it. All right, Peter, does penicillin polysulfate interfere with cartilage healing and growth after an ACI procedure? If so, how long after surgery could a patient consider using it? And he's in Slovenia. That's very, very cool. Okay, a couple things. It's a very complicated question, but I absolutely love that. First of all, ACI is what's called autologous chondrocyte implantation. So if you had, in our knee model, an area of cartilage damage, articular cartilage in a very localized place, what they could basically do is a surgeon can go in surgically, kind of scrape off a small little section of healthy cartilage, send it to a lab that gets the chondrocytes out of that, the cells that become articular cartilage, replicate them, and so that you have this solution that's got hundreds of millions, hopefully, new cartilage cells. And then you go in a second surgery and basically put it in the defect, usually, at least the way it has been done, cover it with a patch of periosteum to hold it in place, and then give it time to allow those chondrocytes to become healthy articular cartilage. That surgery does fairly well. It is not perfect by any means, but in the right patient, that can be a good option. Penicillin polysulfate is a medication, at least here in the United States, and I can't speak for Slovenia, but in the United States, it is still not FDA approved for orthopedics. It is FDA approved for a bladder condition, what's called interstitial cystitis. It's been around for decades. If you Google it, you'll see tons and tons and tons of side effects. That's how it's given for interstitial cystitis, which is a high dose, I think daily medication. So when you see all these terrible side effects, including one with your eyes. Now, granted, it's over a very long period of time, but just know the way it's given for osteoarthritis has not been shown to have those side effects. But for that, it's given as an injection that you give yourself usually once or twice a week. It is in phase 3 trials here in the United States with the FDA. It's expected to be approved probably by early 2025 from what I hear, and I do expect it will have a dramatic effect on osteoarthritis. I rarely use it alone, but as part of a number of different treatments, I think it can be very helpful. As far as when and how you would use it around ACI is a little tricky. Supposedly, and I hear this from one of my patients who is actually a stockholder in Paradigm, the company that's bringing penicillin polysulfate to market, he says they have internal data that shows that it helps with cartilage regrowth. That data, at least as far as I have looked in terms of scientific research, looking at the journals, I have not seen that data published. It may be true that they have early data that shows that. I haven't seen it. What there is data on is that it seems to be very good at stopping the inflammatory cytokines and the degradative enzymes that break up cartilage and bone, that break down cartilage and bone, I should say, and speed up the development of arthritis. So I like it very much to try to slow the progression of osteoarthritis. And yeah, I do think potentially it could be helpful around an ACI surgery. As far as when that would be, it would be up to some debate because it's honestly never been studied that way. It is a mild blood thinner, so I personally would say, hey, maybe start it a week after surgery, and I would not expect that it has any significant damage on the growing chondrocytes becoming articular cartilage, but I couldn't also guarantee that. So I'd have to think long and hard if that's something I even wanted to do in that first 6 or 12 weeks after surgery. It just hasn't really been studied for that purpose. So I don't know that I have an easy answer to that. Is one, whether a patient should do that. Again, you're not a patient, so it's not medical advice. And 2, if so, when the best time to do it. But very, very interesting question. Georgia says, thank you. I definitely keep us informed on how that goes. Omar, the flexion process is really painful during physiotherapy. Could you go through surgery? That would be between you and your surgeon. If it was a patient of mine, I'd probably say around 6 weeks. Just because the sooner you do it, the better, rather than waiting till 12 or 4 or 5 months, where I feel like that becomes even harder to get full range of motion back. But that's a little bit of a matter of surgical preference. I think in the United States, at least, typically we start to think about going a different direction if physical therapy isn't enough around 6 weeks. Mike says, any thoughts on near infrared light for tendinopathies? There is some data that shows that red light therapy is helpful, low-level laser therapy for tendinopathies. I don't know that research really well. It's funny, I created a talk, and so I put some of those slides in my talk, some of those studies. I don't remember them off the top of my head. We don't have, and part of this is we don't have low-level laser therapy in our office, so it's not something that I typically refer out for, but I do know a handful of patients of mine that have gone to providers that have low-level laser therapy for tendon issues, and they have been very pleased with how it did help with pain. With any of these modalities, typically my thought is if the science is that it may be helpful. I've always thought any one of them is not necessarily a game changer by themselves, but as part of something that you think of, all right, maybe I'll do low-level laser therapy, maybe hyperbaric oxygen, maybe shockwave treatment. And again, it depends on which problem you're treating. Maybe it's something like peptides and a variety of other ideas, penisin polysulfate, PRP, exosomes. There's all sorts of different things that sort of come into that list of options in the sort of regenerative orthopedic world, that a certain combination might be effective than any one of them. But the nice thing about red light therapy or low-level laser therapy, especially if it's targeted to a particular area, say the extensor tendon of the elbow for lateral epicondylitis, tennis elbow, I do think it could be helpful if you have access to it, and there's really not much of a downside to it. Any possibility that thyroid problems can contribute to tendon problems? To be honest, I have not read any research that suggests that, but I would also say that's probably something that has not been fully studied. Certainly reasonable. I mean, the thyroid plays a large role in immune function, autoimmune issues, so it certainly could. I just am not aware of any studies to that effect. Should someone have any diagnostic blood work, colonoscopy blood, prior to using peptides like TB4, BPC, possible tumor growth? I've never seen any studies linking BPC or thymosin beta 4 to tumor growth. There are case studies with the human growth hormone releasing peptides like CJC 1295 and by default something like AOD 9604, but that, in fact, I just had a discussion with a patient about that earlier this week, and I've got lots of thoughts on that. Maybe for one of those peptides, you could get an insulin like growth factor 1, IGF-1, before and then follow it along. Typically, it's thought that the human growth hormone releasing peptides like CJC sort of self-regulate IGF within a certain level that's thought to be very safe, but I suppose you could give it in really huge amounts, way higher than probably should be given, and get that IGF level high enough that maybe it would increase your risk of tumors. Specifically for BPC and thymosin beta 4, I'm not aware of physicians that are treating orthopedic conditions with that getting preoperative blood work, and I'm not sure that colonoscopy would necessarily do anything, but certainly an IGF-1 level, I guess in theory, could be helpful. Having said that, I would never tell anybody it couldn't be related. It's just I don't know that there are any studies for those two peptides that do show that as a risk. Harsha says, is a grade 1 meniscus tear problematic? I'm not 100% sure what that means, grade 1 meniscus tear. There are, and grade 1, 2, and 3, this is a radiology classification at signal seen on an MRI for a meniscus. Grade 1 is just a blob of signal within the meniscus. Grade 2 is a little more focal. Grade 3, it extends all the way to the surface of the meniscus and usually on multiple sequential slices of the MRI, which by definition, grade 3 is a meniscus tear, where grades 1 and 2 are intrameniscal signal that does not constitute a tear, but maybe there's something different that I'm not, maybe we're on the same page, or maybe in a different country there's a different classification. Anthony says, I have a 2 millimeter labral tear in my shoulder, autoimmune dysfunction, sarcoid. I've been dealing with the pain for about a year now with physical therapy for about 10 months. I think the trick with this, and again, I can't give you medical advice, so I cannot say what should you do. I can't tell you what you should do. One of the challenges with labral tears, especially a very, very small tear like 2 millimeters, is trying to figure out if that's even the source of the pain. That has been shown, like if you do read these studies where they took, people with basically no shoulder pain at the age of 40 or older than 40 and got MRIs, and a huge percentage of those patients with no shoulder pain, the MRI shows a labral tear. So it's a little unclear in certain people what that labral tear on an MRI actually means. If you're young and a throwing athlete, that probably is the source of somebody's pain. If you dislocated your shoulder, yes, that labral tear probably is related. If you aren't, maybe you could put in there manual laborers might be in that category, but in that setting, it's hard to know. I don't know that I necessarily, I guess I would say I would want in a patient of mine to find out if that's the source of pain. So I might consider injecting just some numbing medicine into the shoulder joint just to see, something like lidocaine, just to see if the pain goes away, to see if that's actually the source of pain. For a small tear, if you say, all right, this, you do whatever, you figure out that is the source of pain, then it gets to the question of, do you go through a surgery, which is a short outpatient surgery, but a 4 to 6 month recovery if it actually needs to be repaired with stitches and anchors, sutures and anchors, or if it's going in and just trimming out part of the meniscus, which that may or may not be, that's still a 6 to 12 week recovery. Is that worth it, or would you try a regenerative treatment? PRP, exosomes, stem cells, to see if you could get it to heal on its own without that. But I think the hard part in that setting would be, if this was a patient of mine, is that actually the source of pain? That's really hard. Mike says, thank you. Wits End with Achilles tendonitis. Yeah, I mean, I think if I've treated a fair amount of Achilles tendinopathy, usually 3 years. It is not an inflammation of the Achilles tendon anymore. If you were to get an MRI in patients with long-standing Achilles pain, what you'll almost always see is basically tendinopathy or tendinosis, degeneration of the tendon, maybe a small amount, maybe a large amount, but the key then is to get that to heal. So, peptides become an option, shockwave therapy can become an option. Don't know as much about the red light for tendinopathies, but may potentially be helpful. But then maybe even injecting something into the tendon to try to get it to heal, whether that's PRP or exosomes or stem cells, but very tricky problem for sure. Alphen says, I rolled my ankle, heard a popping sound playing soccer, visited an ortho, told me to rest for a week. How long will it take to recover? That's unfortunately something I can't tell you, because that would really depend on what an MRI showed if you were going to try to predict it. Assuming it's a lateral ankle sprain, are you talking grade 1, grade 2, grade 3? Because that can be anywhere from 0 to 2 weeks up to 6 weeks, depending on how serious it is. What I will say is, one of the reasons people take so long to get back to play after ankle sprains is they don't get what's called their proprioception and balance back. It's a joint position sense. It's being able to, say, stand on your bed on just that one injured ankle, close your eyes and be able to balance. It's getting those small muscles around the ankle to fire so that somebody can land on it, so that somebody can run and change directions on it. And time is notoriously unreliable at getting that back. I mean, you eventually do 3 and 6 months later, but working with a physical therapist that rehabs a lot of athletes can really speed that process up. The ortho told him it might be a mild grade ankle sprain. So let's just say grades 1 or 2. The rule of thumb typically, and again, this varies a lot, and I don't change what I say about the physical therapy. Grades 1 lateral ankle sprain is typically 0 to 2 weeks return to play. Grades 2 is usually 2 to 4 weeks on the milder side. And then our last of the day, Anthony says, I'm 21, no other injury besides cartilage loss. So that is very good. Very cool that a 21-year-old is insightful enough to come to this show. Thank you guys so much. Lots of really, really good questions. Very, very excited. Our next show is March 8th. Usually I do these later in the month, but I'm just getting deluged with so many comments and questions on YouTube especially, and again, I can't respond to those comments with medical advice, so I'm trying to do that a little bit earlier in the month just to answer more questions. So, and Alphen says, thank you. You are very welcome. I hope you have a wonderful weekend wherever you are here in the United States or around the world. Very, very happy you joined me, and I will see you all very, very soon. Have a great